First question is a brilliant question.
Which one's that? Let's go up again. Yes.
Okay, that's us now showing as live on Facebook. So I will leave you to have an interesting session.
Thank you
We'll catch
very
up with you later
much.
on. Thanks very much, folks.
Thanks, Alan. Good afternoon, everybody. Good afternoon, James. We've got Professor James Neuberger here. I'm hepatologist. And this is squeaky chair. I was going to send him WD-40, but I'm told I'm not allowed to send such substance in the post, so I'm maybe going to drop his wife a wee voucher for B&Q. Anyway, James, thank you so much for joining us. Everybody, whether you're on Click Meeting or Facebook, thank you very much for joining us this afternoon. I've got a sack of questions here that we're going to kick off with. If you've got questions to ask, try and get them in as quickly as you can. And you can do it privately to here on Click Meeting, or you can go onto Facebook where Linda is there and ready to bang them down the airwaves to me. Okay, so we'll give it a start. James, are you well? All good?
Well, good, thanks. Pleased to be here again. Yep.
Excellent. Good. It is the fun hour of the week, isn't it? Okay, first question, brilliant question. Is it okay to use hair dye when you have PBC?
Yes, the background to this, just to put it in context, is people have looked at trying to find the cause of PBC. And one of the ways they've done that is by asking a whole load of questions to people with PBC and similar questions to people without PBC and seeing if there's a difference. And one of the studies several years ago, when I was middle-aged, so that far back, did suggest that people with PBC had a very slightly higher increased risk of having used hair dye. And I think that's the basis of the question. A number of things to say. Firstly, as far as I'm aware, there is no evidence that hair dye or any constituents of hair dye does cause PBC. It's still a possibility, but there's absolutely not a shred of evidence. And as far as I'm aware, and this may be wrong, it's not really been associated with other autoimmune diseases. The second point to say is that association is not the same thing as causality. For example, as people get older, their teeth tend to come out. As people get older, they tend to get bald, certainly men. And therefore, there's a strong association between baldness and having no teeth. But to say baldness causes no teeth or vice versa is clearly ludicrous. Mm-hmm. So, yes, there's a very weak association in one or two studies, but as far as I'm aware, there's no suggestion of causality, and therefore I can see no reason to advise people not to use hair dye if, unlike me, they've got hair, and if they want to use the dye. So I think that's the basis of the question. I have to say we still really don't know what triggers PBC, but as far as I'm aware, apart from that association, there is very little evidence that it either causes PBC or makes it more aggressive. So dye your hair if that's what you want. At the foundation, as you know, we will dye for you. So carry on and do what you want to do. What
makes you happy? It's a good question, and I remember it came up in the questionnaire all those years ago. I've gone back a long time, and it stood to reason if you ask women over the age of 30 they dye their hair, a high proportion do. There was 1 or 2 men who replied yes as well, by the way, which I thought was quite interesting. Yes. So it's interesting. The next questions even I find to me even more interesting, because this has come up on a number of occasions, James, and we all know that smoking's bad for us, right? We know that. So this person says, I appreciate smoking is considered bad, but is it worse for you if you have PBC or any other liver disease? Now, many years ago, you remember the lovely consultant who passed away. Oh God, his name's going right in my head. Lovely, lovely guy from London, the Royal Free. What was his name? Oh,
Andy Barrows.
Andy Barrows, lovely, lovely man, and a very good, very, very good hepatologist. And he once said to me, just in a conversation, that, you know, if you come across people with PBC who smoke, as I did at one time, he says, do encourage them to stop. He says they don't walk hand in hand nicely, or words to that effect. So, so I would like you to tell us what you know in this one, James, because I think this is a really good question.
Right. I mean, I take issue with one of the questions when the person says smoking is considered bad for you.
Okay.
That is not true. It is bad for you.
Yeah.
And there's no such thing as a good or a safe cigarette. And it not only causes lung disease, cancer of various, it causes cancers of various organs, it makes you wrinkled, and so on. So it is bad for you, and it's bad for people around you. So I would disagree with the word considered. Okay. It is. As far as smoking and PBC is concerned, again, there is very good evidence, and some mechanisms for this are understood, that smoking has 2 effects in people with PBC. Firstly, it increases the rate of progression. It increases the rate of fibrosis of the liver.
Wow.
So if you take 2 people who are otherwise identical, one smokes, one doesn't, the one who smokes will have cirrhosis sooner and will probably have liver failure sooner. And that is true not just in PBC, but in other causes of cirrhosis or fibrosis. Smoking is a good way of increasing your fibrosis. So if you want to get cirrhosis, do continue smoking and smoke more, because you'll get it faster. The other thing that smoking is very good at in people with cirrhosis is contributing to liver cancer. So yes, the answer is smoking is bad for everybody. It's far worse for people with PBC. Smoking cessation is really challenging. Most people who smoke don't want to continue. They don't want to spend the hundreds of pounds or thousands of pounds a year on cigarettes. They don't want to poison their families. They want to stop, but it is an addiction, and it is very, very difficult to stop. There are a number of mechanisms that can help you, whether it's patches, hypnotherapy, tablets, whatever. But it is very difficult. One shouldn't underestimate the challenge. There are several organizations that will help you, but it is tough. And if you do want to stop, talk to your local general practice, because they can put you in touch with the services to help you stop. But it is an addiction, and that's why people continue to smoke. Some people do enjoy it. Some people smoke because they want something to do with their hands. Again, like any other addiction, it's complex, and stopping it is important, particularly if you have PBC. And also, of course, people with PBC are more likely to have some lung problems, like fibrosing alveolitis. And if you smoke and have fibrosing alveolitis, it's a bad combination. If you have bad lungs from smoking and need a transplant because your liver's in trouble, your lung disease may prevent that from being an option. So I would, yes, it's an individual decision. It's a personal choice, of course it is, and I would respect that. But if you do have PBC, there are many reasons for stopping smoking. And it is hard. It is a challenge. Do try and get help. See what works for you, and continue to try and stop, because you will stop eventually. But it does take time. It takes patience. It takes courage. But yes, the short answer: smoking is bad for you, and if you have PBC, it'll help progress it more quickly than if you don't smoke.
Okay, James, do you think it's worth us writing an article about this? Because you said a couple of things. I know the dangers of smoking without PBC, and you have some of them, but you said things there I actually didn't know. Do you feel it's worth we do an article about smoking and PBC? Because I certainly didn't know it accelerated in the way you described.
I think giving people information is one of our roles. What people do with it, of course, is their decision. But I can certainly put something for the next Bare Facts.
Yeah, I'd like that very much. And I want to add on to what you've said. Do you remember when we first met, I was a smoker? Do you remember that, James? Okay. And my late husband, actually his anniversary yesterday, my late husband had stopped smoking many years before I met him. And he used to say to me, oh, if I could only smoke 5 cigarettes a day, I've stopped smoking, but if I could only 5 a day. And that put me off trying to stop, because I didn't want to live my life always wanting something I couldn't have. I didn't think I was strong enough to do it. However, I'm going to say something to everybody out there, and what James is saying, I understand what he's saying, that when I made the decision to stop smoking, I didn't, the NHS route and everything else didn't quite work for me, and it put me off what my late husband had said. But I came into contact with a man called Alan Carr, and Alan Carr, who's since passed away of lung cancer, but he was a very heavy smoker, and he devised, there's books out there by Alan Carr. I met him, and he put a system in place. He had franchises all around the country, and it was about £100 to go to his course, and if it didn't work, then you got your money back. That's how convinced he was it worked. And he had a 90-odd% success rate. And I went on the course, and it worked, and I stopped smoking. And he said, when he was alive, anybody in the UK with PBC, I will give them the treatment for nothing. He was very, very, very kind, doing that and offering that. But I would say to everybody, as an ex-smoker, it's really not as difficult as what people think it is if you have the right mindset. But I would certainly talk anybody through it. 3 days and the nicotine is out your system, and the nicotine is the addiction. But also I would ask you to go and look at Alan Carr's books. His books are still on the shelves, and it's worth thinking about. And I wouldn't be afraid of it, because I'll tell you now, if I can do it, then anybody can, because I was a ferocious smoker. I'm not saying do as I do or do as I say, but all I'm saying is it is doable, it can be doable. And I actually don't remember being a smoker. And the most interesting thing is now you could not pay me to smoke. If you offered me £1 million, I could not take a cigarette. And that's true, James. I kid my kids on and say, pick up a cigarette. I keep cigarettes in my house in case anybody comes, visitors to smoke outside, they've run out. You'll never catch me smoking. So if you are a smoker, don't think it's all doom and gloom. There are ways you can get yourself into a positive frame of mind. James, that is, very interesting what you said. Yes, let's take that further, and let's just inform people of what it is that's actually happening to their PBC if they are addicted to cigarettes. So thank you very much for that. That's been really helpful. Can anyone point to any recent information by PBC experts that discusses the use of pain medication in patients with PBC? I know from reading posts that different doctors have different opinions regarding Tylenol and Advil usage. Now, I think these American terms, James?
Yeah.
Can you help me with this? Is one of these paracetamol?
Yes.
Which one?
I'll have to check. I think
right.
I think unless they both are.
Right. Okay.
So Advil is ibuprofen. And I think Tylenol is paracetamol.
Yeah, that's ringing bells. Right. Well, I'm sure you've got something to say on both then.
Right. Tylenol is paracetamol, acetaminophen. Yeah. Okay. So, firstly, just to say a little bit about pain. Pain is not good for you. People think that, and pain doesn't ennoble the soul, in my view. It just makes you miserable, bad-tempered, and hard to live with. So pain is not something to be endured. And people with PBC, as without PBC, need painkillers from time to time.
Yeah.
There are various levels of pain relief, of which the basic ones are probably paracetamol and a group called non-steroidal anti-inflammatories, or NSAIDs, of which ibuprofen is one, aspirin is another non-steroidal, and they are different and they work in different ways. Now, the thing about paracetamol, and I'm sorry for there's a long explanation here.
No.
But paracetamol is taken by mouth. It is metabolized to an intermediary, and that part of that intermediary is further metabolized to a very toxic compound. And that toxic compound is inactivated, if you will, by combination with a chemical in the liver cell called glutathione. So that stops it damaging the liver cells. Now, if you take a lot of paracetamol, 6-7 grams, 8 tablets or whatever, at one sitting, you may exceed the capacity of the liver cells to inactivate the toxic compound. And that is when, in overdose, paracetamol, acetaminophen, if you're in the States, can cause liver damage. So when we see people with paracetamol overdose, they've taken a large amount of paracetamol, they've metabolized it to a toxic compound, and the amount of toxic compound has exceeded the ability of the liver cells to get rid of it and inactivate it. So it goes on to damage the liver cells, and then 3 days or so, 4 days after the overdose, the liver starts to fail and liver failure ensues. And we still see a few patients who need a liver transplant because of liver failure. If you get treated early, you can prevent the liver damage occurring. And most of the people who've come our way for liver transplant assessment are people who've not meant to kill themselves. They've had a row with the girlfriend, with the boyfriend, whatever, I'm going to show them type of thing. And they don't mean to kill themselves. It's a way out. It's a mark of desperation. So what I'm getting at is in overdose, paracetamol does damage the liver. And that is why a lot of people, a lot of doctors included, and other healthcare professionals are anxious that paracetamol can damage the liver, but that's only in overdose. Now, some people are more susceptible for various reasons, sometimes the medication they're taking, sometimes ill health. But in general, people with PBC, even advanced PBC, in general, can tolerate up to 6 or even 8 tablets of paracetamol a day, provided they are taken over the 24-hour period. And we don't advise people to exceed that dose. If in doubt, talk to your doctor. But in general, when I see patients, I say up to 6 or 8 tablets a day is fine. The other point I would make is that if you're having pain, you need to know why. If it's you've been cycling too much, for example, and pulled the muscle, then there's a very good reason. But chronic pain or even severe acute unexplained pain, you may need to seek advice. Why have you got the pain? So the pain relief is just a sign of something amiss. It's usually trivial, but sometimes it's not. So treat the pain, certainly, but find out why you've got the pain and whether it needs anything doing about it. So in my opinion, for most people, up to 6 or 8 tablets of paracetamol a day is safe. So that's fine. Obviously, if you have pain, you can think of other ways of relieving pain, whether it's physiotherapy, heat, TENS, acupuncture, whatever, topical treatments, but that's a separate issue. Now, moving on to non-steroidals, again, that's a different class of drug which has different interactions. And here, in normal people, people who are otherwise healthy, again, there is a slight risk with non-steroidals, particularly inflammation of the stomach. You can occasionally get erosions and even bleeding and ulceration, and you can get kidney damage. So they are very effective pain relievers, but they do have side effects, and it seems that those with liver disease are at greater risk of those side effects, such as gastritis, gastric erosions and bleeding, and kidney impairment. They also have other effects on fluid retention and so on. So my advice to patients normally is, if you have pain, paracetamol is the first line. Non-steroidals may be safe, or the risks of the may be justifying the benefits, but I think you need to go very carefully, consult with your doctor. If you're taking it long term, you need to consider whether you need what we call gastroprotection, something like omeprazole or lansoprazole. The other thing I'd say is that topical non-steroidals, and there are the Nurofen gels, Brufen gel, and so on, they can be effective. The risks with the topical medication is far, far less. But I'm always more cautious using non-steroidals than paracetamol. The other drugs, you're getting to the stronger ones like the dihydrocodeine, the morphine derivatives, and so on, with a lot more side effects and a lot more potential for addiction. But again, you have to, as always with medication, you have to balance the risks and the benefits. As I say, being in pain is not a good thing. And so you want to have the least amount of the most effective one, balancing the risks with the benefits. So if you are in pain, talk to your doctor, and they can discuss with you why you've got pain and what the best way to relieve it is. And as I say, sometimes you have to take the risk, and you have to balance being in pain and all the consequences of that with the side effects. You can help. There's a drug, for example, called amitriptyline, which was used initially as an antidepressant, but in low dose, 10 milligrams, 20 milligrams a day, it helps pain relief. And there are non-medical approaches, as I say, acupuncture, TENS, heat, cool, and so on, that can help you in some sorts of pain. So don't suffer with pain. Seek advice. My own view for most people is paracetamol up to 6 or 8 a day is safe. Non-steroidals a lot more cautiously. And if that fails, you'll need stronger ones. And again, that's something to discuss with your doctor, because they do have side effects. They do have a particular addiction, and that is a very potentially serious side effect.
Thank you. And I'm just going
Sorry
to...
for the long, yeah.
No. It's absolutely, everything you said is valid and very, very important. I'm just going to reiterate again what James said about the paracetamol a day is meaning 24 hours. 24 hours, not, 9 in the morning, 9 till night. 9 in the morning till 9 o'clock the following morning. That's important. And the other thing I would say to you is that, and I'm sure you'll agree, James, you get aches and pains for different reasons. Aging, many of us suffer osteoarthritis. I know I certainly do. Don't discount physios. If you know the reason for your pain, and if you think resting and not doing very much is going to help you, I can tell you now it's not. But have a word with a physio. What was it my physio said to me? Who's married to a doctor. She says, doctors save lives and physios make it worthwhile. Now, she has a point.
Yeah.
And I have terrible problems. I've got a bit of a trapped nerve, and sitting has been a big issue for me. And I sit every week, and it's been a big issue. And I'm now getting somewhere doing what I've been told to do by the physio, not once, but 3 times a day. So do give that a bash as well. But don't think if you are arthritic and you have these types of general aches and pains, that resting and sitting is going to help, because it's not in the long term. It absolutely is not. So that's my little 5 pence worth. I love physios. I think physios and chemists and pharmacists are 2 of the underused medical disciplines in this country. Wouldn't you agree, James?
Absolutely. I think not, and I'd add to that list occupational therapists as well. And with muscular pain, absolutely. I mean, in the old days, people used to be put to bed when they had back pain. Yeah. And now the evidence is absolutely the opposite. Exercise, strengthening the muscles, and muscle spasm, which can be very painful, again, can be treated not with pain relief, but with antispasmodics. Valium is a very good muscle relaxant, injections and so on. So that's why I say, if you have chronic pain, find out why and seek help. And pain relief, painkillers is not necessarily the best option.
Absolutely. Movement is medicine.
Yes, and bowel movement is bowel medicine, but there you go.
You're in a pretty sorry state if you can't. Yeah. Right, okay, we've got loads of questions coming in. Linda's firing them down the line to me as well. So now this is quite a broad question that I don't know if we should maybe just concentrate on 2 things here. This person has PBC and lupus, both recently diagnosed. It's been struggled to sort through them and begin treatment, and I appreciate that. Can you give me general advice or tips on how to best live with these conditions? If you go to our website, just join up as a member. If not, just join. You get all this information. We practice movement as medicine. We talk about treatments for the itch, fatigue, various things. I'd like you to be a bit more specific. But do read our website. I'm not quite sure how to answer this, because I could tell you 100 things and so could James tell you 500 things. But lupus is quite a different beast from PBC, isn't it, James?
Yes, and lupus can affect you in very many different ways. And I'm not really competent to advise you on that. I think learning how to live with PBC is very dependent on the individual, how you're affected, how you respond to treatments. Different things suit different people. Listen to people's stories, but don't assume that what is right for one person is right for another. And one of the good things I always find interesting, and things I find interesting in Bare Facts and on the website, is people give you what works for them, and they're always useful tips. But what works for one does not necessarily work for another. But part of it is accepting a diagnosis. You've got a liver condition that you didn't, if you like, bring on yourself. It chose you. You'll have it at the moment. You'll have it for the rest of your life. And the question is, how do you make your quality and quantity of life as good as possible? And doctors can help up to a point, but other patients and the foundation can also help by giving you help, advice, pointers. But it is tough. and but you've got to get on with it, to be honest. There's no simpler way of putting it.
Well, I think it's important this person is seeing a PBC specialist and a rheumatologist, because rheumatologists, they know their onions with lupus. And sometimes attached to rheumatology big units, there's clinical nurse practitioners. You can see a nurse practitioner and they'll keep a more regular eye on you and report anything back to the consultant. So whoever this person is, please feel free, phone the office and they'll put you through to me and we can have a chat further about anything more specific. And if we can answer anything more specific, please come back. If we don't get it today, we'll certainly get something in for you next time. So I'm currently on it's in the news at the moment, I'm currently on a patch with HRT patch. Menopause symptoms have returned. I'm thinking of using estrogen gel and progesterone tablet. My GP is not keen on oral component. Liver levels have improved since starting on her. So
again, it's very difficult to give general information here. Symptoms of menopause can vary from being nil to very severe. There are various treatments which have benefits and also have risks.
Yeah.
And those risks and benefits have to be tailored to the individual. In general, hormone replacement therapy, whatever sort, hormones can affect the liver. They can affect it in PBC. They can make the itching worse. They can make the jaundice worse. So I think there is the advice I give is to talk to your GP about the symptoms, about the severity of symptoms. There are different approaches, and as far as the liver is concerned, for example, when you have patches or coils or tablets, the amount of, and the type of hormone you're given is different. And if the symptoms are bad, you understand the risks. I personally feel that if the symptoms are bad enough, it justifies the risk. You watch out for any side effects, particularly deterioration in liver tests, and then you can reduce or stop the dose.
Yeah,
but it's a matter of balancing the symptoms. So if you are very severely affected, then that justifies a greater risk than if you've got trivial symptoms. So it's very personal. It depends on the symptoms. It depends on the type of symptoms, your medical and gynecological history, as well as the state of your liver. And GPs specialize now, and there are HRT clinics, but just having PBC doesn't of itself contraindicate HRT, but it makes the treatment a little more need to be more carefully considered, and if you do start it, to be monitored, but it's risks and benefits.
Yeah, I think that sounds sensible, asking the GP if you maybe try the oral and just keep an eye on the blood test, because it's fair to say nothing happens suddenly with PBC, does it? It's all trends, and if she was monitored pretty closely, there's no reason to think that this could be a disaster. So it's worth a further chat, really, with her.
That's right. And maybe going to a specialist clinic and discussing it with your gastroenterologist as well. But in general, as I say, people with very advanced liver disease, you've got to be far more cautious than those with early liver disease. But most of my patients, I've said HRT is fine, provided they're monitored, and usually symptoms are improved until nature heals itself.
That's it. And sometimes, people are on HRT for short periods of time, a couple of years, 2 3 years. And everybody's different. So thank you, James. Next one, I had brain fog and fatigue for the last 2 years. I'm now happy to report I'm feeling much better. Fantastic, great. And a fatty liver was confirmed my last hospital appointment. Now, before the professor goes on to this, we're hearing this a lot. And look, we've been through 2 years of lockdown and COVID and uncertainty and difficulties and everything else. And we're hearing this more and more. It is important. You don't want 2 liver diseases. You just don't. So perhaps you could phone me, or we can have a chat about how you can maybe get rid of some of that fat in your liver, because it can be done. But you do not want 2 liver conditions. I'm going to hand over to James now.
Right. I mean, fatty liver disease is a separate condition from PBC. Fatty liver has many causes. The most common 2 are alcohol and obesity. You can get fatty liver without being obese. Diabetes can certainly give you fatty liver disease, and perhaps, I say there were 2, but diabetes is a close third. If you get better diabetic control, sugars are better, HbA1c measurements are back to normal. If you lose weight, then the fatty liver will improve, and the risk of progression to cirrhosis will therefore greatly diminish. So and people are now moving slightly away from looking at BMI to assessing the consequences of obesity, to girth and to conditions like fatty liver, which is quite a good marker for heart disease as well. So if you have got a fatty liver, which can usually be fairly readily diagnosed with a FibroScan, try and lose weight. And again, like giving up smoking, some people find it easy, most people don't. Exercise is important, but eating less, eating the right foods, and so on is also important. As far as the PBC improving itself, we know that if you take urso, your liver tests improve, your rate of progression is slower. I'm not sure that is the same as your liver improves. Certainly your liver tests do. Your outcome improves. So that's all to the good. If your liver tests are better, you feel better. And that's the PBC is separate. We do believe in general that if you have 2 diseases, whether it's PBC and fatty liver, whether it's alcohol and hepatitis C, that you get a synergistic effect. So the effect of having 2 conditions is greater than just combining one and the other. They are worse. So, but if you're feeling better, that's great. If the fatty liver's getting better, that's a lot better. That's good news. And the main thing is you're better. How you judge your liver, and I think there's something coming out in the Bare Facts next time about what liver tests mean.
Yeah.
And the analogy that we've used, it's like a car. The car can be unusable because the engine's not working, because the tires are shredded, or if you live in Edinburgh, Glasgow, the tires are on, the car's on bricks. The electrics may not be working, or what have you, or the steering. So there's no single measure of the liver's working, or if it's not working, how it's not working. But that's another thing. So glad it's better, glad the tests are improving. If it is fatty liver that's getting better, then your liver prognosis is a lot better. If it's urso, again, your responder, good prognosis. Happy
days. Okay, thank you. My concern is that after many years taking urso, alkaline phosphatase, it's always been at 195. It's now gone to, from 255 in January to 269 in March. I'm going to be started on a new treatment, but I've been told my disease is progressing. I feel extremely anxious. Does these results mean that it's likely to lead quickly to cirrhosis?
The alkaline phosphatase is a very good guide to the efficacy of urso. There are many causes of a raised alkaline phosphatase, of which PBC in the liver is just one. And if somebody's alkaline phosphatase is rising, you want to know why. It could be that you're no longer responding as well to PBC, to the URSO, and that is certainly one explanation. If that is the cause of the deterioration of the ALK phos, then the normal response would suggest a drug like a beta-cholic acid as well. And again, if you respond to that, the prognosis is good. If you don't respond or you can't tolerate it, again, there are other medicines in the pipeline that may be as effective or indeed more effective than the current medication. I would talk to gastroenterologist, hepatologist, and just be sure, does he think it's coming from the liver? And is it the PBC progressing? As I say, there are other causes. For example, if you have gallstones, if you're taking other medications, if you have fatty liver, it could come from the bowel, it could come from the bones. I don't know your age, but even pregnancy puts up the ALK phos. So is it from the PBC? And if it is, then I think, well, are you taking the URSO? Are you on the right dose of URSO? Are you absorbing it properly? And if the answers to all those questions are yes, on the right dose, taking it and absorbing it, then if it's due to the PBC, I say, well, yes, if you didn't have a beta-cholic acid, you perhaps should be a bit more worried than if you do have a beta-cholic acid available. So you've got another treatment to control it.
Yeah.
Would it be preferable to have your ALK phos remaining normal? Yes, of course it would. Of course it would. And so rising ALK phos does need to be taken seriously. It needs investigating and it needs treating depending on what the problem is. Yes, I'd be concerned till I know what's happening. Yeah,
a clearer picture. I had PBC for 12 years, and apart from slight fatigue, I've been well. The last year, I suffered from flu-like symptoms, headaches, sore back of head, slight pain in lungs, deep breathing, aches and tinnitus. Nothing I can really put my finger on. I wonder if others with PBC have this general feeling. Then 3 days ago, a slight bloody stool. Can you get rectal varices? And if so, should I be concerned? Can I just say to everybody, look, if you have a change in symptoms, and there's quite a few changes in symptoms here, this should be reported. Do not sit and wait a year till your next appointment. This is something you should be asking your specialist, your GP, your health team, what they're thinking, and maybe they want to run, their GP might want to run some tests before you go back to your hospital. But this is not any change in symptom, it has to be checked out. And I don't think we should try and judge what this is because we can't. But James, would you not agree?
Yes, and don't put everything down to PBC. Yeah. I mean, it could be your thyroid were underactive, for example. Okay. One would need to know more. The stool, there are many causes of blood in the stool, and yes, you can get rectal varices and they can bleed. If you have bleeding from the back passage, go and see your doctor. The most common explanation is piles. It's benign, usually, and it's often readily treatable. But don't ignore it. Talk to your GP. It needs investigating. It could be rectal varices, but it's much more likely to be something like piles. Normal piles, nothing to do with the PBC. But there are many causes for it, but always take bleeding as a sign that needs to be investigated. You need to know more about the blood, fresh blood, old blood, altered blood, at the beginning, the middle, the end, on the stool, on the paper, and so on. And these perhaps are not questions or answers that should be aired on this forum. But take it seriously, contact your GP, have it. Yes, it could be something serious, but the chances are that it's not, it's just piles. But while I wouldn't get too concerned, it is important to have it checked out, and that's a key thing. Betting on probabilities is not adequate. And if you have PBC, you've got to look at other causes particularly. And yes, it could be rectal varices.
Okay, thank you, James. We've got a few questions. There was one that was handed to us earlier. We don't have the right information. So to the person who's asked about are they a bleeder, should they take cholesterol, we need to get some more information. So Linda's come back to you. If you haven't come back today, we'll pass that on to next week. I've got another question in front of me and my blood's boiling, so I'm going to deal with this one first, and then we've got a few, so I'll try and hammer through them. So this person says, I recently started experiencing pruritus. The PA at my hepatologist office suggested I stop taking Urso to see if the itching improved. If so, I should reduce the amount of Urso I'm taking. I have never read anything suggesting this. What are your thoughts? My personal thoughts are tell her that as she's not medically qualified, you shouldn't be speaking with her. I'm happy that she may pass on a readout or give you a letter from her hepatologist, her boss. I'm appalled at this and I'm fed up. I'm fed up with non-qualified people telling people's PBC to come off their Urso. So whoever's listening out here now and in the future, because this is going on our PBC channel, don't. You do not listen to anybody who tells you to come off your Urso unless you hear it from your hepatologist's mouth or your person who's looking after your PBC and you have an explanation as to why. Right, rant over. You can see why we do the job that we do, why people need us. Please don't stop your Urso, please. James, I'm going to be quiet.
I think if you're starting to itch, again, there are many causes. It could be the PBC. I think there are anecdotal reports of Urso causing itching, but it would depend, for example, on how long you've been on the Urso. If you've just started it, then it's much, then the chances of it being the cause is greater. But I think you want to be sure that the advice is right, that you stop a drug, that you don't want to stop a drug that is going to be have a major impact on the condition. Yes, there are alternatives, particularly obeticholic acid and fibrates. So it's not a disaster if it's Urso related, but it's unlikely. Talk to your hepatologist. You will know, and he can understand how likely it is. If you've been on the same dose of Urso for many months or years, then it's unlikely to be the cause unless the dose is increased. And I would certainly look for other causes. If you've just started it, then maybe that you stop and start at a lower dose and build it up is an option. But talk to your consultant, understand why they think it's Urso related, not the liver condition. Have you taken other medications? Have you started other drugs? Are you allergic to things? Is there a rash? There are a whole host of questions that I would want to know before attributing it to the Urso. As I say, you have one. The other thing to think about when you're thinking about side effects from drugs is that Urso, like many other drugs, come in very many different preparations. And sometimes the reactions are not to the drug itself, but to what are called the excipients, the other chemicals in the tablets, the casing, the content, the buffering, and different preparations of the same drug have different side effects. It's like saying you want a vacuum cleaner, and when you get a Hoover, a Dyson, G-Tech or whatever, they're all slightly, they all do the same job, but they're different. So talk to your GP, don't stop it unless they advise you.
Can I suggest that you don't have telephone calls with a PA? You want to be emailing your consultant or your GP, but a telephone call to a PA, things can be misinterpreted. If anything serious were to happen, there's absolutely no comeback. So just, write an email to your GP or your consultant if you can't see him, and I'm sure he'll give you some things to think about, and he will organise some tests. But not telephone calls. Things can get lost in the wash, if you know what I mean. Okay, thanks, James. Is it common to get osteoporosis when you have PBC? And we're going to have to be very quick now.
Yes.
There you go.
I mean, you're likely to get it because you're likely to be a female, and if you're peri or postmenopausal, that will obviously put up your risk of osteoporosis anyway. But cholestatic disease, liver disease, also risk factors for osteoporosis.
Okay.
If you are smoking, don't smoke, because that'll make it worse. And choose your parents carefully.
And also diet. Diet is important. I used to think it was just what your diet was like before your bones, you were full adult. It's not. It's now. And if you don't like dairy products like I don't, you can look at bread, look it up online or look on our website, but keep an eye on your diet as well.
Calcium and vitamin D and weight-bearing exercise.
Yeah.
So walking is perfectly good way of reducing the risk of osteoporosis.
Yeah. I have the usual dry mouth, dry ears, dry vaginal area, but recently experienced dry ears as well. I've tried a few different creams, but I do have 2 hearing aids. Oh, bless you. I find they block up the connecting tubes of the aids. Any suggestion what I can use for my ears?
In general, I'd be cautious about attributing the dry ears to the PBC.
Okay.
The reason is that it's the cells lining the tubes of the glands that are affected in the Sjögren's syndrome. And this is new to me, and I'll have to look it up after this. But it's unusual for ears to be affected. And what I would do is I would talk to the hearing aid technician, who usually are very knowledgeable, and find out what's going on. But I wouldn't attribute it to the Sika syndrome and the PBC. I'd look for other causes and other treatments and talk to the hearing aid technicians for their advice, or other wearers of hearing aids.
Yeah. Okay. Thank you. Can you give some advice about sugar's poison, and hydrogenated oils, please? I'm assuming they help the disease progress. Ooh, life it's not that simple. I'm not quite sure I know what hydrogenated oils are. No,
likewise.
Right, okay. Sugar's bad for you. Sugar's bad for everybody, whether you've got PBC or not. But does food directly cause progression of?
Not that I'm aware there's any good evidence. Some people find that certain foods, particularly fatty foods, may upset them. They may be intolerant of gluten. If you think you have a diet-related problem, then try altering the diet, provided you do it sensibly. But I've no evidence that either food supplementation or certain diets affect the rate of progress of PBC. But if you find certain foods make you nauseous, diarrhea, whatever, then just do the common sense and avoid them.
Okay. I would like to have more information on damage that medications can cause on the liver with PBC. How do you balance the benefits taking some medication versus not? Of course, I'm not talking about serious illness. This is where your GP and your pharmacist are the geniuses in these kind of scenarios. And of course, you would need a bit of input from your liver specialist. James?
I mean, there are very few, all drugs, all medicines, and I'm including natural remedies here as well, and vitamins as well, and over-the-counter as well, have side effects as well as benefits. And there are very few medications, if any, that have no side effects. And as I say, that includes natural remedies, as well as conventional medication. And you always have to balance the risk of medication against the benefits. There are, how drugs are handled in liver disease is very complex because there's so many factors that can affect it, from absorption to metabolism to being transported in the blood to end organ effects to the fact whether you've got liver damage, whether you've got cirrhosis, renal impairment from the cirrhosis and so on, whether you've got excess fluid, what your pH is changing to, how the bile acids affect, and so on. So in general, you've just got to be cautious. You've got to say, why am I taking the medication? What are the risks? Are they increased by having liver disease? In general, it's unusual. There are certain rules like non-steroidals, particularly in advanced liver disease, avoid them if possible. In advanced liver disease, drugs that cause constipation, avoid. Drugs that cause or potentially cause confusion and drowsiness, avoid. But you always have to balance risks and benefits of for taking any medication. In the same way that in theory, if you're going to get into your car and drive to the shops, you know there's a risk of death. And it's worthwhile thinking, how many people die in this country on the roads every day? It's between 5 and 6. And we ignore that. We live with that. But people need to start thinking and putting adverse reactions from medication in context. There's a whole discussion about how you assess risk, but our perceptions are way out of kilter with reality. As I say, 5 or 6 deaths a day on the roads, and we could avoid that very easily just by reducing the speed to 20 miles an hour universally. Okay. But for obvious reasons, we don't. Anyway, rant over. Yeah.
2 questions. One's very quick. Should people with PBC be considered to receive the 4th immunisation earlier?
That depends on their condition.
Yeah.
The JCVI gives very clear guidance as to who should get it. And if you're offered the vaccine, take it. If you're drowning and offered a life belt, take it.
Yeah, it's interesting. I've just 4 weeks away from having COVID. I kind of am treating that like the 4th vaccine. I feel I've got some antibodies,
It certainly helps. It stimulates the immune system.
Yeah.
And within probably 2 or 3 months, you get the beneficial effect of having it. But we don't know enough about it yet. We don't know if there are new variants, how effective they'll be prevented with natural immunity with vaccine. But I think if you're immunosuppressed with advanced disease, there may be a case for getting additional earlier immunization. But I think just wait till you're summoned, and when you're offered it, jump at it.
Take it, yeah. Last question. What do we know about the reason why some people's PBC experience fatigue? Is there a connection between the AMA, the roles of mitochondria, and energy production that ties in with the symptom? I remember thinking that years ago. Or is this a cellular level and therefore unlikely to be relevant? I'm not even sure that we do know. Is the level of understanding on this topic is low? Is anyone researching it? Wow. Let me tell you, we've got our first fatigue clinic in the world opened on the 14th of February up in Newcastle. Anybody in England and Wales can be referred up there. And boy, are they researching fatigue. And it really is a hot topic. So I'll let you comment on the antimitochondria.
We don't know why people get fatigue, and even Newcastle, where David Jones and his team have done a lot of research, we don't really understand why people get it. There is a hypothesis that, as the questioner alludes to, that antimitochondrial antibodies will interfere with the metabolism, and that leads to fatigue. It's an interesting hypothesis. There's no very good evidence that that is indeed the case. It's a nice story. But as far as I know, there's no good evidence that the higher the antibody titer, the more fatigue you get. I think the fatigue is also variable, whereas antibody titers tend not to be. There's a lot of interesting ideas, but the bottom line is we haven't a clue.
But it's important to say, though, James, that people who do suffer the fatigue, it comes and goes to different levels. Don't go to bed. Just don't lie down to it. Just don't do that. Keep yourself on the move a bit. You know, movement really is medicine.
And the other thing I'd say is that fatigue rarely has significant improvement after transplantation. So you have a
thing, isn't it?
very nice liver.
But
to go along with the AMA story, your AMA persists after transplantation. And so there may well, it may well turn out to be that AMA are involved with the lethargy, but we still don't know that for sure. We don't know why people have lethargy. And also what to do about it other than exercise. People have tried coenzyme Q. Newcastle did a study where it showed no effect. So we don't know. And I'm sure the answer will become clear in the next few years.
But it's great news that they've got this particular clinic where tired, fatigued PBC people are attending, and they will gather more and more information, which is great. We've answered all the questions. Perhaps I'm on to this lady, and I know she's a lady who sent your question in about cholesterol being a bleeder. We need a bit of information. We will cover it next week. We are here next week. But James, thank you very much. I think you answered all those questions very, very well. And I think you should stay in hepatology, actually, if you wanted my advice, which you probably don't.
A lot of people are telling me the opposite, but never mind.
And Chris, Linda, the people in the background, thank you very, very much because I get the message sent to me. There's people working the tech. Thank you for joining us. So a couple of things, people. We're coming into a recession. People are struggling. We're struggling. So those of you who can, would you please go to our website, make a donation, or phone Linda at the office and give her your card. A few bob would always help, because without money, we can't keep up these services. So please, if you would, I'd be very, very, very grateful. We all would. It's for everybody. Not everybody can afford it, but there's many that can. And so that's the first thing. And second thing to say is, James, thank you very much. I don't think we've seen you for a few weeks now. Maybe I think next month we've seen you in June.
I'm not sure when, but yeah.
Yeah, we'll leave Alan in charge of that.
Yeah, but to double check that. But
Alan, thank you very, very much. I see Abby's in. Hi, Abby. I hope you're well. I can't see any of the names.
Thank you both for another wonderful session. Very informative.
And James is going to write about nicotine and smoking. That's a really good call. Yeah, it's brilliant. Okay, everybody, thank you very much.
Okay.
I hope you all can help. Don't hesitate to contact us. Thanks, James.
Thanks both.
Bye.
Thank you.
Bye. Bye-bye now.